So BV itself can be and has been a talk of its own. To summarize, BV is very common. Not all people who have BV are bothered by it, and most people who have it are actually asymptomatic, though we shouldn't be testing people who are asymptomatic. BV is classified as a dysbiosis, so meaning an imbalance or maladaptive alteration in the composition and function of a microbial community, in this case, the vagina. Normally, the acidic environment of the vagina prevents the overgrowth of anaerobic bacteria. But with BV, this environment gets disrupted and shifts from the majority of lactobacilli to the presence of more facultative anaerobes. These anaerobes then produce proteolytic enzymes, which break down the normal vaginal peptides into amines. And if you ever had the pleasure of participating in a chemistry lab, you know that amines have a very foul odor. They also cause a rise in vaginal pH to above 4.5, which is important as part of the diagnostic criteria. And then you also get a desquamation of epithelial cells that are covered by Gardnerella, which you can see in this picture here, G. vaginalis. And those are actually the clue cells that you'll see in microscopy, and that desquamation leads to the vaginal discharge. BV can also lead to complications, and you can see them listed here. So increasing the likelihood of transmission and acquisition of STIs, and then some sort of peripartum complications as well. The pathogenesis of BV is not well understood, though it's really only seen in those who have initiated sexual activity. Prevalence does increase with the number of lifetime partners and the other factors listed here. And it's notable that there are differences in prevalence that vary by race and ethnicity. Recurrence of BV is very common, and that's sort of why we're talking about what we're going to be talking about. The rates are over 50% within 6 months. There are some risk factors listed here that have been associated with BV recurrence, but I do want to pause for just a moment and recognize how huge these numbers are and how that translates into so many patients having to suffer with this over and over again. And if you work in the clinical field, you see this every day. But then this New England Journal article from March of 2025 really shed some new light on the potential for treatment of assigned male partners to prevent recurrence of BV in those assigned female at birth in the Step Up trial. The trial built upon previous research that BV-associated bacteria are in fact found on the male genitalia in this partnership, and with this knowledge designed the Step Up trial to include an intervention of combined oral and topical antibiotics for male partners of females diagnosed with BV, to assess the impact of concurrent treatment of monogamous heterosexual couples. The primary outcome was reduction of BV recurrence at 12 weeks. The study took place at 5 sexual health centers in Australia. It was open label and randomized to concurrent assigned male partner treatment or no partner treatment. And you can see on the slide here the descriptive characteristics of the male and female participants. So the mean age was late 20s, early 30s for those assigned female. About 30% had IUDs in place, lots of BV prior, though in a monogamous partnership for at least 8 weeks at the time of the study. Many of the participants had multiple prior male partners and infrequent condom use. And then on the right here, you can see the characteristic of those assigned male participants. All people with BV were treated with standard of care. Partners were treated with oral metronidazole and topical clindamycin twice a day on the penile skin, or no treatment at all. Critically, this treatment was taken simultaneously. No sex was the ask during the treatment period, and throughout the 12 weeks, vaginal swabs and questionnaires were administered. And again, they were most interested in looking at recurrence of BV at 12 weeks. The results were so promising that the study was terminated early due to favorable interim analysis for the treatment group, with a striking 62% reduction in recurrence rate per person year with partner treatment compared to no partner treatment. You can see some of the details here. So there are clear benefits to oral plus topical male partner treatment based on this study, but there are questions regarding the generalizability of the results, particularly in comparing the US population and the Australian population, where there are different rates of circumcision and IUD usage compared. Both populations are different in that way, and the diversity of the actual population. So mainly white European descent population in Australia compared to not that in the US. New York has also just recently, as mentioned, put out some guidance to help New York clinicians provide this care, consider providing this care. So the New York State guidance recognizes that counseling and how we talk about BV as sexually associated bacteria is a pretty big shift from previous discussions focusing only on the dysbiosis component for both patients and clinicians alike. The authors of the New York State guidance aim to educate clinicians on this, describe male partner treatment evidence that we just reviewed, and then discuss how to approach this. I thought these two quotes were really important. So when discussing a BV diagnosis with patients, it's important to inform the patient that BV is associated with sexual transmission, and effective management may require the involvement of their sex partners, really a shared responsibility and accountability. Emphasis on sexual transmission is a change from how BV pathogenesis and natural history have historically been presented to patients and may trigger questions. So some people like flowcharts. I am one of them. This is just kind of taking what was shared in the guidance and put into this flowchart. And so when a male partner does present to care, begin by taking a sexual history. If they are with a partner diagnosed with BV and plan to continue being with that partner, we can provide counseling regarding BV-associated bacteria, what we just discussed, and offer treatment, which is both oral metronidazole and topical clindamycin for penile application as described. Emphasizing that either abstaining from sex until both partner and patient complete treatment, or if sex is going to happen, the importance of using a condom with the caveat that clindamycin may weaken the integrity of the condoms. Lastly, offering appropriate screening and services based on the other components of the sexual history is an important